introductory talk. And what we're going to talk about today is expanded indications for lumbar disc replacement.
Texas.
Here are my disclosures. So lumbar disc replacement was introduced in the mid-'80s in the old East Berlin at the Charité Hospital with the goals of maintaining motion, improving function, reducing adjacent segment degeneration, and then obviously providing a safe venue of treatment for patients. Since that time, it has been one of the most studied technologies in the history of orthopedics and spine, with over 700 papers from 5 continents, multiple devices, a lot of level 1 randomized controlled trials, including multiple FDA studies, case series, registries, and now long-term follow-up again from all over the world. This is just but some of the papers that have been in the literature with greater than 5-year follow-up. Now, as a basis to compare and talk about the main topic here, the FDA trials were traditionally limited to a very narrow scope. Initially, trials were 1 level except for 1, and very, very specific indications for good reasons. Number 1, a smaller number of patients were needed, reduced the risk of undesirable outcomes, hand-picked surgeons, very hand-picked patients. You might say that it was rigged, but it was rigged against the standard treatment, which was fusion for most of the papers, and you'll be able to see what the results were. So basically, no hybrids, no adjacent segment to fusions, which a lot of us think is an excellent indication for motion-preserving technology. So after approval in the U.S. and frankly, from the beginning and the outset around the world, expanded uses, what we call off-label here in the U.S., were done. And it was important for those of us that were doing it to publish the outcomes, complications, so that if the literature is favorable, perhaps some days these might be covered by our payers and they might get labeling by the FDA for certain expanded indications. So reviewing some literature on TDR. So what does it teach us beyond the indications specifically for the FDA trials? And I'm just going to go over a few. We're going to discuss this paper, and I wanted to point this out because, and I didn't know this before, the randomized control trials, including the FDA trials, are level, we call them level 1, but they're actually level 1B. And a meta-analysis of level 1 studies is level 1A, and this is the highest evidence that exists in the literature, and that's why we picked this paper today, and we'll discuss it in a little bit. Shout out to some of the California guys from Cedars. They published 2 to 4 level disc replacements in a very significant number of patients, and really continued the results that we saw in the 1 and 2 level trials of safety and efficacy. Harry Marnay, who was one of the godfathers of arthroplasty and the inventor of the Pro Disc, presented an early series of multi-level and had good results, but had a higher complication rate than his 1 levels, again, early in the experience. This was the landmark 2-level paper, and you can see it was published in 2011. So it was completed, obviously a year to 18 months to 2 years before that. So it took a decade for the FDA to approve 2-level indications just a couple of months ago. So, and obviously we don't really have any insurance coverage for that yet. This is one of Matt's other papers in his multi-level series as well. Again, excellent results for multi-level. This is the paper of his that we're going to discuss in a little bit. And as far as I know to date, this is the largest hybrid series in the world. His experience with it is, these are all his patients. And thanks to his partner, Lawrence, this is about as big a HIPAA violation as could exist. This is Matt's back. He has a hybrid as well. So not only does he talk the talk, he walks the walk. And this is him later that day or the next morning begging to get out of the hospital. So very quick recovery. So safety, we obviously want to ensure that safety is an issue. And one of the criticisms potentially will be reops anteriorly. I'll talk about that in a second. But if you look at the literature across the world, most papers found that reoperation rate for TDR is less than that for fusion, and there's no randomized studies that found a higher reoperation. So again, reoperations as a measure of safety. This is our experience with our first 1,700 patients looking at anterior reoperations or removals, and you can see the incidence of slightly under 1%. We are now up to, this is our TBI registry from which we pull this data and answer some of these questions. We're up to over 3,000 implantations over a 20-year period. This is our registry by surgeons, and you can see the 3 senior surgeons have each implanted over 1,000 discs over this 20-year period. This study found that a large percentage of the anterior revisions were early. They were early failures occurring less than a month before the index, and certainly before a couple of years. And the interesting thing is the majority of these also occurred early in the surgeon's experience. So some of these are learning curve issue, both technical as well as indications. So the basic indications from which we're going to expand upon this journal club, these were the original IDE indications, which we pretty much adhered to at the beginning, but then with good retrospective registry data, we're able to really kind of expand those a little bit. Now we're up to 2 levels based upon FDA labeling as well. So what did we see with some patients that initially we thought were perhaps not good patients? So this is a very, very collapsed disc. A lot of surgeons would stay away from arthroplasty here, but as you can see, with good facets, it became a technical issue. Can we mobilize this disc? And I believe this is one of Jack's cases, and you can see an excellent result with restoration not only of disc height, but lordosis and a good result. What about recurrent disc herniations? Classically, we were all taught once you herniate a few times, fusion is the right thing to do. Well, if the criteria for disc replacement are otherwise met, meaning not unstable on flexion extension and not too much facet resection with multiple discectomies, we found that these are excellent candidates for disc replacement, and even fragments that are extruded inferiorly or superiorly, much like you do in a cervical, you can fish those out from the front and do an excellent canal decompression and then reconstruction with motion preservation. So how do you stay out of trouble? You stay out of trouble by being very vigilant for contraindications, and this is whether you're doing single level or the stuff that we're going to talk about, and I'll go over some of the indications, contraindications. Osteopenia. The labeling in the US for disc replacement is a T-score greater than or equal to -1.0, which is osteopenia. Obviously, to osteoporosis, you're really asking for trouble. The -1.0 number has kind of come into question because there's some inconsistencies. Some people have advocated using quantitative CT with Hounsfield units. I don't know that there are accepted norms yet for that, but since we're doing CTs on a lot of our patients preoperatively, if we could come up with some norms, we could perhaps not have to do DEXA scans and just use the CT scans. Other contraindications, obviously instability, you got to do flexion extension films. Scoliosis is another one. In the labeling for the discs, it's 11 degrees or more is a contraindication. We have found that in practice, if anybody has more than a 5-degree scoliosis, you're really asking for trouble if you're doing arthroplasty. Pars defects, you can see here in retrospect, you can see a pars defect at this level. As we all know, sometimes at L5S1 with a lot of tissue and bony structures in the way, it's not always easy to detect them on plain x-rays. So we've gone to getting CT scans, not only to check the facets out prior to arthroplasty, but also to look for occult pars defects. Obesity, most of us use access surgeons, and you want an unhappy access surgeon, he shows up at the case and you've got this patient on the table, you might not get him for another case. So in terms of approach, a lot of access surgeons now we've learned like to see their patients preoperatively. So I think that's probably a good idea, particularly when you have questions about abdominal vessels and certainly circumferential calcification. If you're doing 4 or 5 or above, you've got to be very, very wary and perhaps look for another approach alternative and maybe not an arthroplasty. What we found, and we've gone over some of these already, literature is supporting now not contraindications. Age, smoking, prior discectomy, we talked about that. 2 levels we'll talk about in a little bit. And we talked about decreased disc height and the technical ability to mobilize the disc. I'm not going to steal the thunder from the NAS meeting that we may or may not have. This may end up being a virtual presentation. But one of the criticisms at the beginning from the naysayers is, well, if you really follow the indications, only about 5% of your patients who come in are going to be really candidates for this. We look back at ours, and albeit these are self-selected patients, they're coming to a center for disc replacement, and we found, I thought it was 50-50, but when the data came out, it looks like only about 1/3 of the patients had hard contraindications to disc replacement. And as we said before, you can't be a one-trick pony and try to retrofit everybody into a technology. So an anterior interbody fusion is a nice alternative to disc replacement when there are contraindications. So what did we find? We found multiple sources of data from all over the world substantiating this technology. I promised myself that after Tuesday's talk, I would fit in Sig Bervin's term of equipoise. I had to look up what it was, Sig, if you're on this call. And as an equipoise to fusion, you can see that this is a very, very viable treatment alternative. What's not in the literature is a huge number of failure series, a case report here and there. And obviously achieving good outcomes, whether it's single level or the expanded indications that we're going to talk about at the journal club, you've got to be mindful of contraindications, and patient selection is key. Didn't talk too much about it, but psychology, preoperative psychological screening, we find invaluable as well. And we talked about these. So that's my brief talk, and I'm going to hand over the screen to whoever is presenting the first paper, which I think is Alex. Okay. So who's up? John.
Yeah, that's right. All right. Can everyone see me? Okay.
Yes.
Okay. Morning, everyone. My name is John Burleson. I'm one of the spine fellows at Texas Back. I'm going to be presenting this paper that's a meta-analysis on 5-year outcomes for randomized control trials comparing fusion to lumbar disc replacement. There's some different comparisons that happen in the studies, and we'll kind of go over that. But this presentation is going to take about 4 or 5 minutes. It represents a lot more hours of work, crawling through thousands of papers. But the point of this was really to find the highest yield randomized control trials in terms of data that we could compare together to really make a meta-analysis that the authors were able to use to decrease the confidence interval and increase the statistical value of the data instead of just creating, some summary article of a bunch of studies that have already been performed. So let's see if we can, there we go. So on this first one here, you can see the 4 main papers that were combined here. The top paper there from 2010 is comparing ALIF to the Maverick disc replacement. The second one from 2009 is comparing ALIF to the old Charité disc arthroplasty. And then SCOLD is a Swedish study that compared posterior lateral fusion as well as PLIF fusions to either the Maverick, the ProDisc, or the Charité. And the 2012 study there is comparing the ProDisc to 360 fusion. So obviously a little variability in the type of fusion that was used. I think that's representative of the real world, that obviously surgeons fuse differently depending on where they are in their training and their own preferences. But the idea here is just to compare in general the 2 major alternatives, which is fusion versus motion preservation. In doing that, On this first slide here, we're looking at risk of reoperation. The graph on the right shows favoring TDR on the left, or ADR, whatever you want to call it, and favoring fusion on the right. And that changes a little bit on some of these other slides, so we'll point that out. But this is a really good example of what can happen to statistics when you collect similar data across multiple trials and you're able to combine the data together to narrow your confidence interval. So you can see, looking at these 4 papers, the Swedish paper from 2013 is completely in the favor TDR side, and you can see the numbers in the risk ratio there, that the number doesn't cross 1. We go from 0.19 to 0.82. The other ones either don't cross, like in the 2010 study, or barely cross or are in the middle. When we combine it together, though, we have a 95% confidence interval that's clearly on the TDR side of 1 there on the graph, which just tells us that there's a relative reduction in risk of reoperation with a disc replacement versus a fusion. And the numbers there, as you can see, are pretty large. So we'll go to the next one here. There we go. So this one's looking at ODI. Again, a measure that was collected by all of these papers. This one's a little bit closer to that magic number of 1, which tells us which way to go and gives us our statistical significance. But again, when you see the kind of mean in each of these 4 studies, they're all on the side of TDR. And then when we're able to combine pretty good data together, we're able to make something out of that. And in this case, we can say that you're more likely to reach ODI success, as defined by greater than 15 or greater than 25-point improvement with a disc replacement than with the fusion in this studied population.
Hey, John, can you go back to that first slide? So I just want to point something out, because I learned a lot about meta-analyses and forest plots. So if you go back to the first slide, go back to that one. So 2 things that I learned. Number 1 is, by pooling all this data, you can apply stronger statistical analyses. So this is a risk ratio. And basically what it says is, what's the risk of this outcome in each of these groups? So by having a 0.5 risk ratio, it's the risk to a patient who randomized to TDR is only 50% of having a reoperation at the end of 5 years than the cohorts of patients who were randomized to a fusion. So the risk ratio is just statistically stronger than a p-value or other comparisons. The other thing is the I squared. If you see that last thing under heterogeneity, I really had no idea what that was, but the lower that number, the more homogeneous the groupings of the patients are and the outcome instrument. So when you have an I squared of 0, it means that the inclusion-exclusion criteria basically for all of these groups were identical, and that the instrument or the question that you asked was crystal clear. So here it was just, did you have a secondary surgery or not? So it is very clear, and the groups had the same inclusion-exclusion. So when you see an I squared of 0 in a meta-analysis, it means that all those patients were the same, and that the question that they were asked was the same. So you can appreciate the data much better when you see that number than if you see it at 75, which means there's tremendous heterogeneity among the groups. So just little things that I picked up, looking at a forest plot, which before were sort of murky, but it helped my understanding of the quality of data analysis. Sorry, John, keep going.
No, as always, it's appreciated. I think, the other thing that I picked up early on from y'all's paper here is that, we're starting with over 1,000 papers that you found that, based on the title, might meet the criteria. So you're really culling it down to the papers that will specifically give you that I squared value that you need, which is what allows us to have statistical data that's of value compared to, I think, at least a lot of the fellows and young surgeons. When we were residents and we're first seeing these Cochrane database reviews, a lot of them really read more a lot like summaries of a bunch of trials that have been done with different metrics, and it's not really as valuable for making a real decision. So we'll go to, we talked about ODI, this back pain. So this one's an example of one that does cross the line a little bit. You would say, if you're in favor of this, that it trends in the direction of favoring a TDR. If you're not, you would say it's not statistically significant, or however you want to phrase that. But the important thing here is, when we look at where the data is, we have, again, that bottom total with our 95% confidence interval, we're favoring the side of disc replacement at this point in time. If we doubled the number of patients and studies, maybe it moves further that way, maybe it doesn't. But right now, we know it's at least not worse than fusion in terms of back pain reduction.
And the interesting thing on this question, John, we know that the patient groups are homogeneous from the I-squareds on all the other questions. The reason this I-squared is 36% is because the question was indistinct. So from study to study, when you have a patient draw a number on a VAS line, some of them say, what's the worst pain you've ever had? Some studies say, what's the worst pain you've had in the last 30 days? Other ones say, what's the worst pain you've had today? So it was interesting that the heterogeneity is in the most simple thing in the world, which is draw a line on a line. But that is a confounder. It's not the patient population. And that's one of the reasons why this is not as a reliable, this one's not statistically significantly better, although it's numerically better favoring the artificial disc patients, but it loses that crystal clarity, not because of the patient population, but because of the question that was asked.
And then when we look at this one, which I think is very important in terms of your patient population, is what's their satisfaction overall with the procedure? Is this a patient who's likely to do it again or, tell their friends it was great? And so in this case, again, we have the same four studies that we're looking at, and we can see that they all trend numerically individually towards favoring an ADR or a TDR for their condition. But with our combined data there, we're able to see that, of course, the 95% confidence interval is all above that value of 1 there, indicating that that's more statistically than a fusion. So although I think none of us would love to have a back surgery if we don't need one, it kind of indicates that with the people that had it, they are satisfied with that. So this is just kind of a really quick, very simplified version of what did we get out of this. And essentially tells us that the papers individually and then at the bottom together tell us that, ODI is better or improved more reliably with the ADR. Reoperation rate is a little bit lower. Patient satisfaction is better. Back pain is better, depending on what you believe about that, might not be enough to influence what you can say to the patient reliably will be improved versus a fusion. And then the last thing here is just, as Dr. Blumenthal mentioned, there's a lot of papers now on this subject, where the reason these papers were chosen was because not only were they similar in the measures that they looked at, but also because we were looking for 5-year data. So things like the ActiveL didn't have 5-year data at the time of publication on that. That's starting to happen now. So as these other publications come out with these similar criteria, it makes sense that in the next few years we'll be able to make stronger statistical arguments for some of the points made here and possibly in other areas as well. Thank you.
Good job, John.
All right, we have 5 minutes left for any questions or discussion. Anybody on the faculty want to chime in? Or anybody else? Chat, question? If not, we'll go on.
Yeah, John, I'll start. Terrific presentation of really important data. And thanks for explaining some of the subtleties of the meta-analysis. That does make the forest plots more clear. This GOLD study really seemed to have the biggest effect size, and their comparator group was posterior-based interbody fusions. Is that something that you've seen in other literature as well, or maybe others can comment on the ALIF versus TLIF as the comparator in the fusions, because that really seemed to compromise results of the fusion compared to the ALIF studies.
Yeah, I mean, that Swedish study allowed them to use 3 different disc replacements and 3 different fusion techniques. I think one was an ALIF, but the other, you're right, was a TLIF or even a PLIF. But it was a prospectively randomized multi-center trial where the patients were followed at the same intervals as the US IDE studies. So that's why it survived all the cuts, going down from the top of the chart to the bottom of the chart. But it was also good to have something outside an IDE experience, because as Scott alluded to, IDE is sort of a carve-out. You're taking very specific cherry-picked patients and cherry-picked surgeons, and that's always a criticism of an IDE study, will it work for the general population? Whereas the Swedish study was a much more generalized study and invited a lot more surgeons who were doing community-based surgery in their institution, so they could choose the implant they wanted as well as the procedure they wanted, but they followed it with the same scientific principles. So it was actually good to have that in the mix. And you can see the data analysis sort of points out some differences, which is fine. It's okay for us to look at that and evaluate it. But it was a welcome addition because it did generalize the applicability of the outcomes to most surgeons in the world rather than just IDE surgeons selected in the U.S.
Yeah.
So we saw it as more of a positive than a negative, Sig.
Yeah, and it's interesting because when we did the Charité study, we just compared it against an ALIF, and we thought that was a great comparator. And then when Jack and the Protis people did the Protis, they compared it against a 360. But in reality, what it shows is that we're doing the same operation, and compared against all these different fusion techniques, it still comes out to be superior.
So a quick question. You guys mentioned that you do the arthroplasties when there's a recurrent herniation. And I know from the ALIF work that I've done is with people with recurrent radicular symptoms, that even with the ALIF, that many times they'll end up with some residual recurrent radiculopathy, even if you pull the fragment out from the front and do a good decompression. And so a lot of those, I routinely decompress posteriorly to get a predictable result for them. And just interested, with the arthroplasty, do you feel you need to decompress them? And what incidence of people who have radicular symptoms with a recurrent herniation are you finding that you need some posterior surgery?
That's a great question. When we first started doing them, we would always kind of warn the patients that, we'll just do it from the front, but we may need to go in the back and decompress your root. And while I don't have the exact data, I can think of maybe only a handful of patients that we've actually had to do that. And I think Rick was about to say something.
Yeah, Tom, that's exactly right. We weren't sure what was going to happen, but what Scott said is that I can't remember the last time I went back. I did have a patient last December that had a caudally extruded fragment that was way behind the L5 body. And I told him, I said, I'm not sure I can get this from the front. But lo and behold, with the little tiny nerve hooks and ball probe, I managed to pull this massive thing out. But I told him we might have to go back in. But most of the time we can get it out. And as Scott said, and I think Jack will confirm that, it's a rarity that we have to go in from behind. And we've been very satisfied with favorable results rather than seeing patients with residual radiculopathy. If they've had a lot of scar tissue and it's not really a soft disc herniation, that's another story.
All right, let's move on to the next paper. We're right on time.
Oh, yeah. I would say we had the same experience when I was operating with Delamore out here. We would always go in the front, caution them about going in the back. If it was a herniated fragment, it was very rare you'd have to go back, even with extruded. Sometimes with osteophytic spurs, you might have to go. That was the same experience here in LA.
Yeah, and I think it's obviously, following on what Todd said, it's very satisfying when you see that other centers that do a lot of this stuff have very similar experiences. Kind of reinforces our own feelings about it. Thanks, Todd.
Good morning, everyone. My name is Abhi Gandhi. I'm one of the TPI Spine Fellows. Thank you, Seattle Science, for hosting this journal club. So I'll be presenting Dr. Scott Young's paper. It's on the outcomes of the hybrid procedure. Okay, so the background behind this study is essentially, we all know the benefits of individually the TDR procedure as well as ALIF. However, they do have some corresponding pitfalls to them. For the TDR group, you can have some patients complain of facet pain, arthrosis. There's signs of rotational stability. For the ALIF group, there's increased signs of adjacent segment motion disease, and sometimes non-unions. Therefore, out of these concerns, the hybrid construct was started, going into effect and became more popular for patients with multi-level degenerative disc disease as a sort of balance between the two individual solutions of TDR or ALIF. And this is especially useful if you have patients with multi-level disease and one level is more unstable than the other. And, in shorter follow-ups and smaller series, hybrids have shown significant improvements in visual analog scores, as well as disability scores versus standalone constructs. However, there haven't been any long-term prospective studies, and therefore this paper was written to evaluate the long-term clinical and satisfaction outcomes in patients that underwent hybrids. So they had about 620 patients over the span of 14 years. The inclusion criteria were very strict. Patients with multi-level discogenic axial low back pain, more than a year of symptoms that have failed to respond to non-operative management. And all of these surgeries was performed by Dr. Scott Young. The implants were variable over the years based on availability and surgeon preference. However, all of the ALIF patients, all of the ALIF levels did get BMP. The outcome scores that were collected were pain, VAS scores, Rowland-Morris Disability Questionnaire, and ODIs. And satisfaction grades were scored on a 4-point scale. The results, the median follow-up was approximately 3 years. There was a 25% loss to follow-up, mostly in the first few years. However, over the course of 96 months, the cohort showed that there was a significant decrease in the ODI scores from baseline, approximately 64%, and this stayed significant at every single time point, which is very powerful. And this was true for all of the other outcome scores as well, including the VAS leg and back pain scores. And more interesting and I think significant, one of the most significant findings of this paper is all of the profiles outcome scores showed significant improvements well above the minimal clinically important differences. So that is very powerful in the graphs. You see the horizontal line being the minimal threshold for it to be clinically significant, and all of the outcome scores were well above that. And patient satisfaction were good or excellent in more than 90% of cases, with a very few minority of patients that did not improve post-operatively. So once again, to reiterate, the findings of the paper, there have, as seen in the graphs and illustrations and the tables, there were significant improvements in all of the outcomes measures. And this is significant because the results were better than papers with focusing just on patients with TDR and fusions, and comparable to some of the literature, pre-existing literature in support of this paper. One by Dr. Noble in 2010 with a series of 47 hybrid patients. They had a very similar decrease in ODI scores and improvements in VAS back pain. Jacobs in 2012 had a satisfaction rate of approximately 82%. And in this study with a lot more patients, they found a satisfaction rate of more than 90%. And this is very significant for support for the hybrid construct. So I think the biggest takeaway is, the hybrid construct based on this paper and the largest series yet in literature showed consistent and clinically significant results for at least 8 years after surgery. More than 90% of patients were satisfied at the final time point. These are some of the limitations. As with every prospective study, there is some loss to follow-up. The variety of implants used is a notable point. However, the technique and the surgeon, being one surgeon study, I think somewhat balances that out. And some of the patients at baseline did not have leg pain, so that can be that result can be taken with a grain of salt. But overall, I think this paper shows very good data over a long-term period for the hybrid construct.
Thank you. Good discussion. I'd like to, for those of you who weren't on early, like to introduce the author of the paper, Matt Scott Young from Gold Coast, Australia, and Bond University. And it was nice of him to stay up to almost midnight on a Friday night in Australia. Matt, you want to make some comments?
Yeah, we've had the rugby league on tonight, and normally I'm drunk by this stage, so it's a pleasure to be here. Can you hear me all right?
Yeah.
Okay. In regards to, I'm hearing an echo. Can you hear
Yeah,
an
you're getting
echo?
some feedback. Is your
Getting a lot of
Yeah, I'll sort that out. Hang on, give me 1 second. Just talk, Scott, and I'll shut that echo.
So while he's fixing it, the interesting thing about the hybrid is, there's a couple reasons the hybrid came along. Number one is many times L5S1 is pretty arthritic and with set disease and in a further, advanced of a degenerative phase and not really a candidate for multi-level. But in the US, as well as in Australia, some of the reasons for hybrids are economic because we could only get one disc level approved. We still basically can only get one disc level approved. And initially the insurance companies didn't really look that closely and we were able to get the hybrids approved. Now they are much more granular and they have the same issue in Australia, a single level approval. So some of it's economic, but the data has shown that it's a very viable and in fact sometimes preferable alternative to multi-level. Do you fix, Matt?
Yeah, right. Good. Yeah, so with the evolution of that, Scott's quite right. Some of it comes down to necessity, some comes down to what you see as a patient. Everyone loves the one-level disease at 5'1". I mean, that's an easy fix when you make a decision based on, basically the type of spine, the quality of the bone, where the radiculopathy is, the facet arthropathy, etc. And, you can replace or fuse and you'll probably get much the same result. My comment about the excellent dissertation of the review in the literature before, particularly with back pain on the forest plot, is you see that, functional results are better with disc arthroplasty, no question. But back pain results are much the same. And I would concur with that. I have a large series of single level fusions and disc replacements, and I really can't pick the difference between the two. All I see long-term down the line was the adjacent motion segment degeneration that does occur. But I think that's ultimately dependent on the amount of lordosis and restoration of balance that you achieve through your fusion. In terms of the common thing we see is multi-level disease. And so expanding from fusion to arthroplasty through the 90s, I kind of saw the role of maybe, maxing these things together. And I was really strict with the indications early on. We were all taught with Charité, and the majority of these patients are Charité, that you really had to treat back pain only. But in the course of that, the odd herniation came up, and it's just like a giant ACDF. You open that disc space, you can decompress that quarter equina, you can pull those herniations out. And I discovered along the way that leg pain can be sorted out. Now, in the good review of the paper there, one of my acknowledgements of the limitations of this paper was that not all patients who presented with multi-level disease had leg pain. I do usually verify the presence or absence of radiculopathy through quantitative EMG, and that's a bit of a niche area that we don't really have time to talk about. But there was a variance in the presentation of leg pain. So we had a very wide IQR ratio from anywhere from 14 to 80. And when you look at that leg pain, 25% of patients had less than 1 out of 10, but 25% had greater than 80%, 8 out of 10, 80 out of 10. So what we were able to do is we looked at that group and we found that we were able to reduce leg pain significantly. And that's when I changed my tune in terms of what arthroplasty could do and what we could do from the front by managing the whole disc at any compressive areas. The only thing I think we can't change is that lateral recess stenosis. So that's where sometimes, you do the decompression, then you do your reconstruction at the front. Now, in terms of some of the papers that will come out of this, we didn't find any difference in the type of arthroplasty we use. The majority of this was Charité, moving to InMotion. There was a few sprinklings of the Maverick and a little bit of the Pro Disc. Looking back on it all, that's a tough disc to do, that Charité. You had to balance everything. And I then produced, at the time, a paper that's just been published recently on 2-level arthroplasty and 3-level arthroplasty. And that shows exactly the same results. And so when I look at my 1 levels, my 2 levels, my hybrids, they're all exactly the same. And we're going to produce a paper on that soon. We've already presented it last year at the Spine Society down here. So I think the big trick in multi-level disease is not being afraid to restrict yourself to a technology. I think the important thing is to match the technology that we have with the pathology that the patient has, and not necessarily have a preference for a particular technology. Just acknowledge the fact that this is what we have to do at this level. And I think that as time's gone on collectively around the world, we've seen the importance of sagittal balance, stable fusion. We know arthroplasty works. It gets people back functionally. And I think it's a real exciting time we're moving into, and hopefully the innovation continue to maybe some of these, one-piece elastomeric discs, who knows, but one disc that can make life a little bit easier in terms of facet arthropathy and coronal plane instability. I think we'll all agree that the Pro Disc and the Charité you had to be precise. You really had to balance everything to get that disc in. It's like doing a single unilateral knee replacement. You really had to balance things, otherwise things went wrong. We've continued to monitor the results, and we now have 20-year follow-up, but obviously it's another 10 years before we can do the 20-year follow-up. But the results are improving because our attention to detail is improving, and we're looking for modification of implants to improve the outcomes as well, and measuring against any negative results. I just want to thank Scott and the TVI team and Jack and Rick for giving me the invitation to stay up till 12 o'clock on a Friday night when I should be, asleep.
We do have time for some questions, Matt. The one question I would ask is, in our series of hybrids, obviously not as large as yours, we use BMP also on our ALIFs. We've not seen one non-union of the fusion component of the hybrid.
I'd love to answer that. I would tell you this, that we've recently had BMP withdrawn from the Australian market, and it was not because of safety and efficacy issue. It was because of a regulatory issue where when Medtronic, originally sophomore Danik, came down, they registered at the Therapeutic Goods Association as a device. In other words, selling the BMP with the two cages. And some whistleblower blew us out of the water recently who got fired from Medtronic saying there was a technical irregularity. So it's prompted me to go back and look at all the BMP, which I've used. And I've used BMP in fusion since 2002. So I viewed 3,000 CT scans during this COVID period. And we looked at flexion extension films. BMP, as you can see from the Maverick trial, and that was probably the best trial to look at real fair income fusion versus arthroplasty. Arthroplasty still beat it. Now, with BMP, you can get that 100% fusion rate. It just takes away the variables of bone graft, non-union, lock suit arthrosis, all of those sort of things. So we're in a bit of fight with TGA down here to get BMP back on the market. But I would concur. I think that's one of the great inventions of all time, and it's revolutionised spine care. And unfortunately, we've just stepped back into the 18th century in Australia. We're back to doing bone grafts.
Matt, can I ask you your comment on what do you think the technical challenge of a two-level ADR is versus a hybrid? And, which do you think is more difficult? And what do you think the outcome difference is? And I'd be interested in Todd Landman's comment on that after yours.
Yeah, well, I can give you the results straight away because they're both available in spine for you. There's a two-level arthroplasty and there's a hybrid procedure. And if you look at those two, the curves in terms of back pain, leg pain, functional outcomes, there's no difference. And what we're going to do is show you that. In terms of technical difficulty, it's far more difficult to do a two-level arthroplasty. You have to balance the annular resections. There's so many variables in relation to that. Doing a fusion is a nice, straightforward, easy procedure. You're going to get sagittal and coronal balance. You just do a wide discectomy, etc. I'm not telling you guys anything there. I think though with disc replacement, particularly with Charité, it was like balancing two points on top of each other. I think when I did the two-level Pro disc, they were much better constrained and you didn't see the coronal malalignments. But if you were off with the Charité, then you had a coronal imbalance, and you basically got a segmental scoliosis. And so it really prompted you to be very careful with the annular resections and sometimes even downsize on the more cranial prosthesis. so that you were able to, have a thicker annulus to prevent any coronal plane instabilities. I think with these one-piece devices, I think that's probably where we're heading in arthroplasty. We still have a lot to do because we're going to have this catastrophic failure with M6s in the future, and that's probably going to put us back a bit because what the naysayers will do is just lump it all into one category, and that's sad. We got exactly the same results in our two-level replacement as you did, Jack. Same stuff. If you look at them, there's no difference between the two. And I think that, careful attention to detail, surgical technique, that's all critical. But, hybrid versus two-level replacement, I love doing the two-level replacement, but I think it's a harder operation.
Todd, do you agree?
Matt?
I think that the two-level replacement is fabulous results. And certainly my gut intuition is I have a slightly better outcome than the hybrid, but I think they're relatively equivalent and certainly superior to two-level fusion. But as Matthew's saying, there is a technical challenge in placing here center rotations properly. We don't have, Matt has a hybrid with an ESP disc. Well, we can't do that here. So, and I want to hear more about your ESP. Your brother's been out here, Matthew.
You can't help bad luck, mate.
Yeah, yeah. He's
known as the virus.
He's a force. He's a force. He's a handful. Gave me a nice rugby jersey. But anyway, certainly at L5S1, I will often just default to fusion there. There's very little risk to that, and certainly with high slope angles and for obvious reasons. But I think that like Matthew's saying, I think I've had comparative results with two-level arthroplasty lumbar versus hybrid lumbar. And I wanted to ask, Matthew, have you had any experience on upper-level arthroplasty and bottoming off with fusion? And are your results there similar, if you have an experience with that of significance?
Yeah, I do. We sub-analysed, and that's in the hybrid paper. That's yet to be published too. We sub-analysed all the different combinations, and we found no difference. So whether we replaced fused, say over 3 levels, or replace fused, or fuse replace fused, as long as I matched the technology, we were good. The adjacent motion segment degeneration, it's interesting. If your top is a fusion, you've got a disc below it, which is a reverse hybrid. As long as you've restored that lordosis, the actual adjacent motion segment generation rate isn't much higher than normal arthroplasty or two-level arthroplasty. So I think some of the magic comes in with the restoration of disc height, lordosis, and motion. If you do a reverse hybrid and you end up with, say, a disc replacement at 5.1, your incidence of sacroiliac joint pain dramatically reduces.
Yes.
And that's something that's interesting. So motion at the L5S1 level is good. I agree with you that 5.1, you've got to look at the type of spine. If you've got a type 4, forget it, fuse it. That's a great thing to do. There's nothing wrong with a fusion, provided it's anterior. It's posterior fusion that in a young man that I have an objection with.
Absolutely.
Yeah.
I think that I believe, anterior cervical surgery is so superior. I rarely want to go in the back at all, even to do a decompression, because I just don't like stripping musculature and changing the function of the insertions and the alignments. And so I think, I prefer lumbar anterior approaches for almost everything, just to avoid muscle damage and stripping and changing.
You're going to have to turn in your neurosurgical union card,
Unless I have to decompress a nerve. But I was asking Matthew, just really for selfish reasons. I have 3 pro discs in me at L1, 2, 2, 3, 3, 4. And Delamarter, when he put him in, this was 10 years ago, and he said, do you want me to do L4, 5? It was completely normal. Then it turned into bone on bone over the 10 years. Started hurting a lot. So I had a X-Lift and Perk screws, which, by the way, Perk screws hurt like hell. I don't care what all of you say, all these minimally invasive, it's bullshit. Well, those Perk screws hurt more than any surgery I've ever had. And I've had 8 spine surgeries now. So my L5S1, for whatever reason, is normal. So I'm wondering.
Prophylactic TDR.
Right, I know. I was thinking, should I just throw a disc in there now before it fails?
Matt, I have a quick question.
Yeah.
So if everything was perfect, you didn't have to worry about insurance, what would your preference be? And the patient was an ideal candidate for disc replacement. hybrid or two-level disc replacement?
Oh, I'd go
4551.
Yeah, I go to disc replacement, two-level disc replacement. It's they're better so quick, and they don't have all the the BMP side effects that you get in the first 6 to 8 weeks, and that limits them. You want to get these people back on the road, so I'd go, if I could, I'd do two-level disc replacement. And it's embarrassing around the world that we have, insurers and governments that make clinical decisions for us. And I think the patients need to be informed about this, and this is why we should publish and talk about this sort of stuff, because it's up to the decision solely lies with the patient and the doctor. And the interference of these third payers and insurers is really absolutely reprehensible. But we have laid our own nest in some ways, and now we need to get out of it. But no contraindications, good bone, normal facets, two-level degenerative disc disease, two-level replacement, first, second, and third.
Well said. Well said. So we're going to move on. I don't think we're going to have time to discuss it, but I want Alex to have full time to present the last paper.
Perfect. Thank you. Can you guys hear me?
Yep.
Yes. Yep.
Great. So good morning, everybody. My name is Alex Satin. I'm one of the TBI fellows. I'll be discussing the 2018 clinical spine surgery article by Radcliffe and colleagues, 5-year reoperation rates of two-level lumbar total disc replacement versus fusion. Results of a prospective randomized clinical trial. Of note, the study was sponsored by the manufacturer. Next slide, please. Perfect. This article is of particular relevance due to the recent FDA approval of the ProDisc for use at 2 consecutive lumbar levels, and it's perfect segue from the last talk. So prior studies have demonstrated a lower rate of radiographic adjacent segment degeneration after single level lumbar disc replacement when compared with the single level fusion, as you can see from Dr. Ziegler's 2012 article. When compared with single level fusions, multi-level fusions place increased stress on the adjacent levels due to the increased loss of motion and longer moment arms. So given the lack of prior studies comparing the reoperation rates after multi-level arthroplasty with multi-level fusion, particularly at long-term outcomes, the authors aim to compare the rates of secondary surgery for patients who underwent 2-level arthroplasty versus a 2-level 360 fusion at 5 years, and to also identify risk factors for these secondary surgeries. So these were patients from the original 2-level FDA IDE randomized clinical trial that were followed at annual intervals up to 5 years. They were randomized 2-to-1 arthroplasty to fusion. Control patients underwent a 360 fusion with femoral ring allograft. No BMP and DBM based on the surgeon discretion. And then the posterior lateral fusion was performed with pedicle screws and iliac crest autograft. I think this was brought up earlier, but I think some had questioned the choice of a 360 fusion for the 1-level study, but I guess it was the general consensus that this was more appropriate in the multi-level fusion cohort. And I think it'll be interesting if we have time to discuss the methods and biologics that were utilized for the fusion patients. At 5 years, the number of arthroplasty patients undergoing secondary surgeries was significantly lower than the fusion patients. Overall, the majority of the secondary surgeries were performed at the index level, and the rate of secondary surgery, the index level surgery was also lower in the arthroplasty group. The rate of adjacent level surgery was lower in the arthroplasty group, but this was not significant. And this was a similar finding in the single level study, and we can talk about that a little bit more. There were a total of 12 index level secondary surgeries in the 11 fusion patients. Of note, 9 of these were instrumentation removals. And this is relevant because if you exclude these instrumentation removals, there was no significant difference between the treatment groups regarding reoperation. And overall, excluding these removals, the overall rate of secondary surgery was 3.5%. The reoperation-free survival was significantly lower in the arthroplasty cohort, as you can see in Figure 1. Multivariate analysis did identify a number of baseline factors that were associated with an increased risk of secondary surgery, and this included fusion, increased age, prior intradiscal electrotherapy, as well as prior discectomy. Oops. There we go. So while the arthroplasty group had a lower rate of secondary surgeries, these findings were, somewhat clouded by the fact that the majority of the secondary reoperations in the fusion group were just simply posterior hardware removals. And the authors made note of it in the discussion that the indications and exact workup and reasoning for this was unclear, and acknowledged it as a limitation. It's interesting to note that only 2 of the revision surgeries in the fusion cohort were due to pseudoarthrosis. And while it's just speculation on my part, perhaps if they didn't use posterior instrumentation, there would have been a lot more revision fusions for pseudoarthrosis. A recent meta-analysis or systematic review rather found that standalone ALIFs without BMP had a 15% pseudoarthrosis rate. So, that's something to discuss perhaps. And then, we often discuss how these findings may impact our practice. And, it's been clear at TBI, but, it's also clear from this paper that in appropriately indicated patients, 2-level lumbar arthroplasty is certainly not inferior to circumferential fusion in terms of index and adjacent level reoperation. And then, the overall level rate of adjacent level surgery was low, which made it difficult to find a significant difference. And as I said, it was also the case in the single level study. And it may be in partly due to the fact that this was originally planned to be just a sub-analysis to address some early concerns about implant migration and wear, which were never borne out. And I think ultimately when we get to the longer follow-up, we'll see that the difference in adjacent segment reoperation becomes more significant. So, thank you.
Thank you, Alex. I guess we have to wake up Dr. Blumenthal, our moderator. But
you didn't have to wake me up. I was answering chats. So
okay.
Trying to be a multitasking moderator, co-author of this paper, sir.
Very nice. No, nice job, Alex. This study was enrolled almost concurrently with the single-level study. The single-level study started in October of 2001. The 2-level study started its first case in January of 2002. So it was enrolled over just short of a 2-year period. So the enrollment period was January of 02 to somewhere in late 03 or early 04. And then the data was analyzed for 2-year follow-up and published, and continued to be analyzed to satisfy FDA at 5 years. So that's where this database came from. And then, as you all know, it sort of sat in limbo for mostly economic, political, strategic reasons. And approval was never sought from the FDA again until just recently, when Sentinel was able to get FDA approval just a couple months ago. So it's an older database. It was the early learning curve for all the surgeons that were in it. Everybody was kind of doing on-the-job training with their 2-level cases. But I think it's good to go back and look at that data, see that it was no worse than 2-level 360, which I think is a real-world comparator. You could argue with a single level that standalone ALIF or lateral something else, or TLIF would have been a better comparator if you were designing a study today. But for a 2-level DDD, I think a 2-level 360 is still kind of the standard of care. So against that, I think it stands up very strongly. And as Scott said early on, we just have not seen the catastrophic failures that were predicted in 2000 when Charité started and the ProDisc started its study as well. So the data continues to accumulate. It's very broad, it's very deep, and it kind of gets better with age, just like a lot of the wine that's behind Dr. Blumenthal there. So, I think we can all be proud. It's a lot of work that went into it. There's a lot of man hours on the surgeon side, but a lot more man hours on the company sides supporting these things and getting people to come in and monitor our data and make sure that it's all clean, and then get it through the FDA and get it commercialized, and continue the fight now to try to get it reimbursed so that patients have access to it. So it's been an ongoing struggle for 20 years for those of us who are involved in it. But the good news is it's the real deal. We have the strongest data of any implants that we put in the body to back us up.
Well, this was a great discussion. We're at our end. This was a great journal club. I want to thank the presenters or TBI fellows, the faculty, Sig Bervin for teaching me how to use the word equipoise, and for the Scully guys, we couldn't leave you alone. Matt had to mention Russelli type 4 spine, so hopefully that kept you guys interested in as well. So much appreciated.
Hey, Scott, this is Rod from Seattle. I'm just going to put in a plug.
Great journal club. Outstanding. The best one we've had, guys.
Have a good weekend, everyone.
Thanks for watching. Hit the subscribe button for more medical content.